Involvement of airway and not the parenchyma is present in obstructive airway disease. This is a normal bronchi or the bronchiole, but this is a diseased chronic bronchitis. Why? Because of muscle contraction, inflammation of the airway, and presence of the mucus. In obstructive airway disease, if you look at it, this is a normal bronchus, but this is a diseased because of muscle contraction, because of thick mucus. There is flow inward but not outside because of the narrowed airways, which leads to reduced expiratory airflow and increased airway resistance. Whereas this alveoli, it is an emphysematous, it is destroyed. Also, it does not contain the muscles. So the air is flowing in but not able to go out, leading to hyperinflation and air trapping. All this can be demonstrated in spirometry by decreased FEV1 and decreased ratio. Common obstructive airway disease is asthma, which involves airway remodeling. Then there is muscle contraction and thick mucus secretion present. It's a heterogeneous disease characterized by chronic airway inflammation. It is also characterized by wheeze, shortness of breath, chest tightness, cough, which vary over time in intensity and together with variable expiratory flow. Whereas COPD is also a heterogeneous lung condition characterized by dyspnea, sputum production, and exacerbation, which leads to airway abnormality, which is bronchitis, or the parenchyma, which is the emphysema, which causes persistent and progressive airflow obstruction. Whereas bronchiectasis is permanent and abnormal dilatation of one bronchi or bronchiole or many because of various affections to the lung and the bronchi. This is the signature appearance of the bronchiectasis. Whereas cystic fibrosis is an autosomal recessive condition because of defect in one gene called the CFTR gene, which is cystic fibrosis transmembrane conductance regulator gene, because of which there is thick mucus which presents, which blocks the airway, which leads to bacterial infection and a vicious cycle, finally leading to dilated airways. Also, it involves multi-organ involvement, mostly the pancreas. There are other conditions like small airway obstruction, that's panbronchiolitis, which can also be considered. In exacerbation of obstructive airway disease, if you look at the um, bronchial asthma, we first look at mild, moderate, and severe. In mild, patient is able to talk. The respiratory muscle rate is normal. There is no muscle use. There is no V. Saturation is more than 94. Then you can use salbutamol or budesonide formoterol combination and reassess the patient. In cases of moderate presentation, saturation is less 92%, excessive muscle use, and V. In these cases, salbutamol, ipratropium, and oral corticosteroids can be given. If life-threatening condition, then it is a silent chest respirate of more than 30, saturation of less than 92, and the patient is confused, sinused, unable to talk. In these cases, ICU admission or hospitalized administration is required. Patient to be started on oxygen, systemic corticosteroids to be given, and obviously bronchodilator, that is salbutamol and ipratropium, can be even given by MDI with spacer or nebulizer. Always assess the patient after 1 hour and see whether the patient is improving or desaturating. If these patients are improving, then we have to discharge this patient. So we have to give them MART therapy, which is the maintenance therapy, which is formoterol and the ICS combination. And you can also give reliever therapy, which is the salbutamol ipratropium, and assess these patients. You have to tell them the inhaler technique, correct device use, adherence, and ask them to follow up after 4 weeks. For COPD patients, again, we are doing the classification to mild, moderate, severe of exacerbation. So for mild, if the dyspnea visual analog scale is less than 5, RR is less than 24, heart rate is less than 95, and saturation is more than 92%, and a CRP of less than 10% is a mild. But in moderate cases, dyspnea visual analog scale of more than 5, RR of more than 24, heart rate of more than 95, saturation is less than 92%, and CRP is more than 10, ABG showing hypoxemia, then it is moderate, and in severe cases all the above, but ABG shows hypercapnia and hypoxemia. In these cases, we have to assess and manage them either in the ICU or hospitalization or send them home. So the treatment includes of non-life-threatening condition is bronchodilator, short-acting beta agonist and anticholinergics. You can always change it to long-acting bronchodilator if the patient is stable. You can either give it by nebulizer or spacer with MDI. Oral corticosteroids is indicated and antibiotic empirical therapy is indicated if the patient has positive sputum, secretions, or patients requiring any intervention or mechanical ventilation. You can always go for HFNC, NIV, or mechanical intubation. Other treatment includes monitoring fluid balance, low molecular weight heparin, and to treat underlying conditions like heart failure and arrhythmias. Okay, so in HFNC, remember this is the nasal bronchs, this is the water for humidifier. Here we can verify it to till 100% with the temperature set with the flow rate set. These patients are to be given HFNC who have persistent hypoxemia, who are unable to tolerate NIV or have contraindication for NIV or when weaning the patient from mechanical intubation. In cases of NIV, we have to see if the PaCO2 is more than 45 and a pH of less than 7.35, if the patient has persistent hypoxemia or shows signs of respiratory failure, which is increased work of breathing, respiratory accessory muscle use, retraction of the intercostal spaces, and muscle fatigue. Intubation is required for the patients who have respiratory failure or hypoxemia, or if the patient has hemodynamic instability, ventricular arrhythmias, diminished consciousness, or massive aspiration, unable to tolerate HFNC or NIV, or post-cardiac arrest or respiratory arrest or intubation. So we always have to give them the maintenance therapy. Better to give triple therapy always. Check for inhaler technique. You can always give steroids and antibiotics, assess for oxygen plan, and treat the comorbidities and ask the patient to come less than 4 weeks. There are conditions that mimic the exacerbation. One is pulmonary thromboembolism. To do a D-dimer while scoring in a CTPA, this CTPA shows saddle thrombus embolism. This is the case of ST segment elevation and STEMI with ST segment depression, which can be determined by ECG, echo, and NT-flow. Heart failure can be differentiated with X-ray, echo, and NT-probe, which shows pleural effusion, capillization of vessels, curly B lines, and hilar enlargement. The pneumothorax, obviously, this is the collapsed lung and the air in the pleural cavity, X-ray or ultrasound. And this is pneumonia with the patch here, sputum inhalation, CT for and X-ray. So 68-year-old man who's smoker, worsening dyspnea, sputum virulency, fever, respirate of 20, saturation of 84, and an ABG shows type 2 failure. Most appropriate next step is to give high flow oxygen, no, because type 2 respiratory failure. Intubation mechanical ventilation can be withheld because patient is conscious, alert, and cooperative. NIV is the best solution to maintain target saturation of 88 to 92. Intravenous aminophylline, we have not ruled out arrhythmias at present. Nebulized bronchodilator alone cannot should be given. We should involve empiric antibiotic and ICS combination. Thank you and Jai Hind.